Welcome to the CHCI Leadership Conference breakout session, Nuestra Salud, addressing Latino health equity in treating chronic conditions. This session is possible due to the gracious contributions from our sponsors, United Health Group, Amgen, Pfizer, and Novartis. Representative Grace Napolitano is today's panel host. She represents California's 32nd District and is the highest-ranking California member and Hispanic member of the U.S. House Committee on Transportation and Infrastructure. We are also pleased to introduce Victor Bulto, President of Novartis Pharmaceuticals Corporation, who will provide welcoming remarks. Our moderator for today's session is Jacqueline Garcia, a reporter at La Opinión, one of the largest Spanish-language newspapers in the United States. She has covered topics ranging from education to immigration and has authored numerous stories about Latino health and health equity. Please welcome Representative Grace Napolitano.
Hello, I am Congresswoman Grace Napolitano, and I proudly represent the California's 32nd District. Thank you to CHCI for putting on today's briefing and for inviting me to participate. Now is the time to continue to raise public awareness about mental health and encourage those in need to seek help. It is vital that we educate our Latino community on this very important issue and reduce stigma. We have come a long way in making mental health a priority in Congress and at that state and county and local level, but mental health still remains underfunded and misunderstood and still affects millions of people. This is largely due to long-standing stigma and health disparities, and, of course, COVID is also worsening the existing mental health crisis. We see and hear it on news, TV, etc. If we address stigma with service early, we can help students and families of color succeed. It is very critical that we provide schools the resources to create a mental health plan in schools to help the students during this stressful time and beyond. I know this firsthand from my decades of direct local involvement. In 2001, after learning that 1 in 3 Latina adolescents had contemplated suicide, I secured $500,000 in federal funding from SAMHSA for a pilot program that lasted until 2009. We partnered with Pacific Links in Los Angeles County and started the now successful Youth Suicide Prevention Program. The schools were very resistant at first because of stigma, but the program has grown to start 35 schools and is now funded by the Los Angeles County. It serves as a model for HR 721, the Mental Health Services for Students Act, which would provide funding for school-based programs nationwide. HR 721 passed the House in May. We hope it comes to the Senate floor soon. Machismo and other cultural tendencies still prevent our loved ones from being open and honest about what troubles them. I have introduced HR 2529, the Mental Health for Latinos Act, to address this issue. It directs SAMHSA to develop and implement an outreach and education strategy to promote mental health in our Latino community in Spanish. We further would identify gaps in access during this pandemic and help reduce stigma. Legislation forces the message that is an absolutely zero shame in asking for help. Our work continues, but it cannot and it must not be limited to Congress. I encourage all of you, everybody, get involved. Continue to educate all your elected officials from local, state, and Congress on this very important topic, and then share your knowledge with friends and family. If you see someone who has fallen on hard times, talk with them, help them out, and refer them to mental health services. The National Suicide Prevention Lifeline is 800-273-TALK. Together we can strengthen the mental health well-being of all of our communities and eventually live in a world where there is no stigma. The new phone numbers 988 will be in effect next July, I believe. So we hope that we'll come across so we can help everybody. Stay safe and God bless.
Hello, I'd like to welcome all attendees of this session. I'm Victor Bulto, head of US Pharmaceuticals at Novartis. And globally, as an organization, we nearly reached 800 million people with our innovative medicines. Buenas tardes, me gustaría dar la bienvenida a todos los participantes a esta sesión Soy Víctor Bultó, líder de productos farmacéuticos de Novartis en Estados Unidos. A nivel mundial, como organización, llegamos a casi 800 millones de personas con nuestros medicamentos innovadores. As society emerges from the COVID-19 pandemic, we face a monumental and dangerous confluence of epidemics, in part due to mass disruption in diagnosis and treatment of serious chronic conditions. Heart disease is the second leading cause of death for family, friends, and neighbors in the Latino community. On average, Hispanic women are likely to develop heart disease 10 years earlier than non-Hispanics, but only 1 in 3 Hispanic women are aware of their risk. The pandemic has also exacerbated these conditions. For example, more than half of Hispanics say they would be scared to go to the hospital if they thought they were having a heart attack or a stroke because they might get infected with COVID-19. And conditions such as high rates of heart disease, high blood pressure, diabetes, and obesity are common in the Latino community, in large part because of health inequities such as lack of access to healthcare and nutritious foods. In order to address these many unmet needs, we need to reimagine our approach to healthcare, especially for underserved communities. And while there has been rapid progress by industry, government, and nonprofit organizations to address the pandemic, we need to apply the same urgency, ingenuity, and collaboration to tackle the chronic diseases and conditions that pose a threat to our population. We are committed to addressing disparities in care in the Hispanic community and other underserved communities by increasing access to medication, information, and support for patients to help close some of the historical gaps in care. And we can do this by pioneering and partnering on population health approaches that will reduce morbidity and mortality of chronic diseases like heart disease, equitably and at scale, and contribute to meaningful, enduring change for generations to come. For example, Novartis is supporting the ASCVD management initiative that has been launched by the American Heart Association with the plans to increase the number of adults with well-controlled LDL-C, or bad cholesterol, by 15%. From a policy perspective, addressing barriers to care, disease management and treatment, such as preventative services and medicines, can have an impact on communities, including specifically earlier and more testing and screening for cardiovascular disease, greater access to cholesterol-lowering therapies, and other prescription medicines that can improve heart health. I'm honored to be opening this session where leaders will discuss both challenges and advancements in addressing chronic conditions to make the health of our Latino communities a priority. Thank you very much. Muchas gracias.
Hello everyone, my name is Jacqueline Garcia and I'm a reporter at La Opinión newspaper. I am pleased to be here to moderate this important conversation titled Nuestra Salud, addressing Latino health equity in treating chronic conditions. Thank you to Representative Napolitano and Mr. Victor Bulto for the remarks, and thank you to CHCI for providing the platform to discuss this incredible important topic. While Latino Americans continue to make advancements in health access and equity, our communities are still disproportionately impacted by chronic health conditions like diabetes, liver disease, osteoporosis, Alzheimer's, cancer, and mental illnesses when compared to white Americans. Compounded by structural inequities around access and comprehensive care, high rates of these comorbidities in Latino communities were exacerbated by the COVID-19 pandemic, and as a result, the Latino life expectancy in this country fell by almost 2 years, from 81.8 to 79.9 years. This session will elevate the issue of Latino health equity as it relates to the successful diagnosis and treatment of chronic conditions and bring together leaders in the health sector who have implemented solutions designed to make the health of our communities a priority. We want to hear from you, our audience, so please submit your questions via the chat box. You can also continue the conversation on social media using the hashtag CHCI HHM21. I am pleased to introduce our panelists who will share their take on how we can address Latino health equity around understanding, diagnosing, and treating chronic conditions. We have Dr. Hayes Bautista, a distinguished professor of medicine and director of the Center for the Study of Latino Health and Culture at the David Geffen School of Medicine at UCLA.
Pleasure to be here.
We also have Dr. Jaime Murillo, Senior Vice President at Optum Labs at the Chief of Cardiometabolic Officer at United Health Group.
Well, thank you, Jacqueline. Thank you, CI, for the opportunity to be with this distinguished panel.
We also have Beatriz Faro, the Regional President of Inflammation and Immunology for Pfizer in North America.
Buenas tardes. Good afternoon, everyone. I'm really pleased to be with you today.
And we have Michelle Carrillo, the Head for Advocacy Relations for ACMEN, where she's responsible for developing and overseeing ACMEN's global engagement strategy with patient advocacy organizations and professional societies across ACMEN's therapeutic areas.
Thank you, Jacqueline. It's great to be here.
Perfect. So we are going to start. Let's start with some introduction. What is your role and why this issue is important to you? Let's start with Mr. Bautista.
Thank you. Well, the largest, most impactful disparity that I'm working on is the Latino provider shortage. Whether we're talking about communicable disease or we're talking about chronic disease, the Latino physician shortage, the Latino dentist shortage, the Latino nurse shortage, the Latino mental health worker shortage is the most important point of contact. Why is it important? Well, lack of Latino providers means that the Latino community doesn't have access to all the prevention information, doesn't have access to early detection, doesn't have access to diagnosis, doesn't have the same access to treatment. And in fact, we can just see how this works both in breast cancer and in COVID. Because, for example, with breast cancer, although Latinos have a lower age-adjusted mortality rate for cancer than non-Hispanic whites, and Latinas have a lower mortality rate for breast cancer than non-Hispanic whites, once a Latina has breast cancer, she is far more likely to die because she is less likely to hear the prevention message, less likely to be able to see a physician early enough to have it detected or have it diagnosed. Usually when they come in, it's at a far later stage, which means the fatality rate is much higher. Not because there's anything wrong with Latinas, it's because of the Latino provider shortage. How large is this provider shortage? California gives an example. There are 15 million Latinos in California, only 7,000 Latino physicians. There are same number of whites, 15 million non-Hispanic whites. They have 61,000 physicians. Latinos are missing 54,000 physicians to have the same access to diagnosis and treatment as non-Hispanic whites. And the rate at which all the California medical schools, public and private, graduate Latino physicians, it will take 500 years for that shortage for 2015 to be made up. This is why for Latinos, this is a big issue. Here comes Senora Gomez. Either she has a temperature or raspy cough, or she thinks she felt a lump on her breast. Oh, Senora Gomez, you would like to see the doctor? Please take a seat. And the doctor will see you in 500 years. This is the most important issue.
Thank you, Mr. Bautista. Mr. Murillo?
Yeah, thank you, Jacqueline. Great to hear about the work that Dr. Hayes Bautista is doing on behalf of our Latino population. I personally committed to this work for several reasons. One, I'm from Colombia. I had the privilege of training my initial years in medicine over there. Spent 1 year working in a rural community, the most rewarding year in my professional life, and then was able to come to the United States and spend 10 more years training and research in medicine at both Harvard and Yale, and practicing cardiology. So as a cardiologist, I'm extremely familiar with the concept of chronic disease. I know how important it is. I know how important it is for the Latino community. Interestingly enough, we think that cardiovascular disease is not as prevalent as cancer in the Latino population, but we'll talk about it later on about the rising trends, both on the male side and the female side. And now working with United Health Group, I think is what I call a match made in heaven, because Our organization has been committed to solving issues in equity for the past 2 decades. If you look at our history, both in identifying, addressing, and monitoring equity, both internally and externally. Internally, we have arguably the most diverse healthcare company in the world. 70% of our workforce are women, 40% are people of color, 12% are Latino, and we continue to do more work internally to develop our Latino leadership and workforce. Along with Dr. David Hayes Bautista, we believe in the need to provide more opportunities for providers to connect with the Latino community. We also work closely with our different groups in the community in the states that we serve to address inequities in healthcare. In the Medicare Advantage population, we have the privilege to serving almost 27 million people. Interestingly, 53% of the Hispanics actually chooses our healthcare company for their Medicare Advantage, and 98% of them are satisfied with our services. We understand the need to address not just the healthcare needs, but the social needs of our Latino community. And I know we're going to spend more in during our conversation, but very excited to share with this panel how we can not only work internally as an organization, but also how we can partner with local organizations and also with national organizations. As we say, we think globally, but we act locally.
Perfect, perfect. Thank you, Mr. Murillo. Ms. Faro?
Hi, thank you. So my name is Beatriz Farah, as you said, and I'm leading the Inflammation and Immunology Business Unit at Pfizer for North America. And our group comprises like a big group of colleagues that have deep experience and relationships in rheumatology, gastroenterology, and dermatology. So I very much look forward to talking to you today about the inequities, especially in dermatology when we think about the Latino community. I would like to highlight that Pfizer Inflammation Immunology is fully dedicated to developing treatments that help enable freedom for all patients with chronic inflammatory diseases. These conditions are very debilitating and distressing and can dramatically affect what patients can do. And we've talked a lot, and Dr. Hayes talked about the impact on cancer, for example, in the Latino community. And later when we talk, I will address a little bit more about the impact of these chronic diseases, inflammatory chronic diseases in the Latino community. First of all, I would like to thank the Congressional Hispanic Caucus Institute for having me today here in the panel. And just to say, I'm really excited to talk about this topic because when thinking about my role at Pfizer, I'm aware of the often unseen impact that chronic conditions have on people's mental health and the physical well-being, and also the disproportionate toll that these conditions have on community of color and on the Latino population. So I very much look forward to discussions in this topic in more detail.
Perfect. Thank you so much. And lastly, Ms. Carrillo.
Thank you, Jacqueline. So I do lead the team and have the privilege of overseeing Amgen's relationships and initiatives that we take with patient advocacy groups, community-based organizations, and professional societies across the world. And our partnerships have been very much focused over many years on addressing health inequities across not only our therapeutic areas that we're in, but across the broader healthcare system. And so another component that our team does is we make sure that the teams at Amgen are listening to the advocates from the Hispanic community as well as other communities of color to ensure as we're developing not only treatments but solutions that they're actually meeting the needs of those patients with those diseases. This issue is deeply personal for me, being a first-generation Cuban American, growing up in a low-income community in Miami. It is a privilege and I feel it's a responsibility for me to make sure that I'm creating a space for the Hispanic community to be heard and to have a voice in their healthcare. So thank you again, and I look forward to a great discussion with this distinguished panel.
Excellent, perfect. So let's start with David. David, can you set the stage a bit more for our audience? Of course, COVID has radically uncovered for the public many health inequities that have long been present. What do we mean when we talk about Latino health inequities, specifically when it comes to chronic illnesses? And can you give us an overview of some of the primary trends and numbers that I have seen in recent years with chronic illnesses in the Latino communities?
Certainly. And we need to distinguish carefully between chronic and communicable. However, the COVID crisis shed light on longstanding inequities. The primary inequity for Latinos, inequities, are lack of access to care. The shortages in providers across the country, and the shortages are growing, by the way, they're not getting any better. The lack of health insurance, and basically in places like California, the fact that the medical institutions in the state have turned their back on Latino health for 170 years and suddenly want us to show up and get vaccinated. Actually, for chronic disease, which are style of life diseases, they're really more the result of how you live your life, what you eat, whom you work with, whom you relax with. Actually, Latinos do quite well compared to non-Hispanic whites. On an age-adjusted basis, we have 30% lower mortality for heart, 30% lower for cancer, 60% lower for chronic lower respiratory disease, 10% lower for stroke. In fact, about the only ones for which we have a higher mortality are diabetes and liver diseases, but they're far rarer. Generally, we have longer life expectancy. Now, here's the thing about the difference between chronic and communicable. I cannot breathe on you and give you a heart disease. So the lack of access to care might not seem as critical for heart or cancer as it would for communicable. I can breathe on you and give you the coronavirus, and that can have effect within a matter of days. But the same issue applies, that the production of Latino providers has lagged horribly, and it's getting worse. The ability of PIs in the laboratory to study what's really appropriate. How do Latinos manage to reduce the risk for heart disease by 30%? That would be headline news anywhere else, but here we just kind of forget about it. And the lack of nurses, dentists, mental health workers all have this insidious effect. We can buffer it with our lifestyle with chronic, but with communicable, there is no buffering because it's very much a relationship of the disconnect between the healthcare industry and the Latino community. That's why I keep focusing on the provider shortage. That's the crux of where I'm working.
Perfect, perfect. Anyone else wants to add anything about the primary inequities that you see in the field?
I'll jump in. Go ahead, Beatrice, please.
Oh, okay. Okay, now I would like to talk to you about one chronic condition that is impacting Latinos and African American disproportionately, and that is atopic dermatitis. And this is the most common chronic inflammatory disease, skin disease. And if we think about numbers in the United States, for example, atopic dermatitis is more common among Black children compared to white children. And this is affecting their daily lives, because when we think about Blacks and Hispanic children, they are more likely than white children to miss school because of the effects of atopic dermatitis. But it's not just about this, it's also about diagnosis, and Dr. Hayes touched a little bit on diagnosis too. When we think about diagnosis, there's one analysis that was done in the US that found that around 60% of patients of color with AD symptoms reported being diagnosed, compared to nearly 67% of non-Latino whites. So we are talking about having more prevalence of atopic dermatitis in people of color and Latinos, and then the impact of skin conditions such as these ones, such as atopic dermatitis, they are underdiagnosed in this population. And there's also a topic that Dr. Hayes also touched on, that there is an underrepresentation in medical dermatologists, and there's also an underrepresentation in clinical research. And this is part of the issues of the inequities that we are seeing specifically in atopic dermatitis.
Jaime, do you want to add anything else?
Yeah, so I'll try to be brief, but there are three topics that I would like to add. One is related to Dr. Hayes Bautista, the access part of it, which I'm sure we're going to talk a little bit more down in the panel. But it's important that we have that ability to give them access, but it's also important that we resolve the issues around access, meaning social issues like transportation, food insecurities, housing problems, and so on. And we'd fortunately be part of an organization like United Health Group, where we can actually tackle all those issues from different angles. For instance, in the last 10 years, we have invested more than $500 million in housing development, in affordable housing for people with adverse conditions and disparities. We have also, last year alone, we delivered 70 million meals to people who had food insecurity and so on, because we understand that health access is not just about purely clinical part of the story, but we also understand that we need to develop sensitive, culturally sensitive information. So that's another topic that I think we can expand further on. And then the last point that I want to make is the data, is that we are fortunate to have access to a large amounts of data. And just to illustrate the point, for instance, last I did an analysis over the past 10 years of heart attacks. And now we can see that, as I mentioned before, the trends in heart attacks are going up in the male population, both in male and female. And the male are now number one cause of mortality. For the females, Hispanics is the second cause. But the trend is moving toward being the primary cause at some point. And if you add to that the fact that we have high rates of diabetes and obesity, and that even though hypertension, you could argue we don't have high rates of hypertension, we will also argue that we, the Latinos, had the lowest rate of both management and control of hypertension. So that's a recipe that we're going to pay for if we don't address those issues early on. So we're committed to addressing both the clinical and the social aspects, because we want to provide more individualized care in a culturally sensitive manner.
Perfect. Thank you so much. Thank you for your answers. And as all of you mentioned, and some of these inequities in health outcomes are often structural, baked into the research and how we understand illnesses to begin with. What are some of the ways to stem these inequities, for example, clinical trials or other research?
Well, if I can jump in, again, for me, who makes these decisions about not only who gets into the clinical trials, but what is being tested? What exactly is the reason why Latinos have 30% lower mortality for heart or cancer? What is the protective thing that we have in Latinos? That's never been studied. And we should be having clinical trials on that if you can figure out how to put it in. But the professionals, the providers are the decision makers. They decide where things go, whether they're this one-on-one office practice or whether it's as a policy maker. We saw this so clearly in the COVID, that the measures that were offered first to try to prevent COVID, unplug your laptop, work at home, worked wonderfully in Beverly Hills. It worked terribly in Oxnard, a town of farm workers who cannot grow strawberries in their front yard. We defined essential workers as clinicals, not doctors and nurses. We made sure they got their personal protective equipment. We didn't even think of giving personal protective equipment to the farm workers. So it's the people making these decisions, how to prevent it. They are familiar with Beverly Hills. Their measures work very well in Beverly Hills. Oxnard or Central Valley is not on their radar group, and they could never figure out how to give the same level of protection and detection to Latinos in those areas as they were providing for Beverly Hills. It's a matter of the epistemology of injustice. Who is making those decisions, and what do they know about these populations? Again, the Latino provider shortage, the Latino principal investigator shortage is hobbling this healthcare system.
Anyone else wants to add anything?
Yeah, thank you, Jacqueline. Well, you talk about research. I'm part of the Optum Labs, which is the R&D arm of United Health Group. So as I alluded before, we're studying these issues because at the end of the day, our goal is to try to erase from the clinical community that concept that because you are X race or ethnicity, too bad, this is what you're going to get. So in order to do that, we need to get, again, deep into the data, and that's where we acquired even more data. We included AI into our algorithms, and AI that is, by the way, has to be free of biases from that standpoint. But we also understand the need to gain the trust of the Latino community, because we know if we're going to talk about research, a lot of injustices have done in the research in terms of research, and I don't need to remind anybody about what was done in terms of sterilization, for instance, in the Latino communities and so on. So we need to engage them in a transparent way. We need to make sure that there's diversity in any clinical trials that we do. We need to make sure that we understand those conditions using our vast data of research. But more importantly, we need to engage the local communities. We need to engage people at a local level. We need to engage them through trusted sources. and partnering with those local sources. It doesn't have to be healthcare only. We can partner with media. We can partner with faith-based communities, because we know the Latino that has a problem with access, but also has a problem with trust. And if we need to trust, we need to earn that trust by telling them that we are really providing a care that is, again, sensitive to their needs, and that we're not just going to say, sit here and wait for the doctor for 500 years, that we're going to say, sit here and you're going to see the doctor, or we're going to reach out to you through telehealth, which we haven't touched upon, in order to meet your needs.
Perfect. Michelle, do you want to add anything else? Oh,
yeah, I would
Beatriz.
love to build on what. Oh, sorry,
Go ahead, Michelle. Go ahead, Michelle.
Thanks, Jacqueline. I'll just build on what Dr. Murillo was saying. I do believe industry has a big role to play in making sure clinical trial sites are more accessible, and we are engaging the Latino community in even the clinical trial protocol design. When we look at what the barriers are, and at the high end of the statistics, we look at what Latinos participate 6-7% of participant enrollment. Some statistics go as low as 1 to 2%. Even though the advancements in the cancer field are moving so fast, and the overall general population, the survival rates are increasing, unfortunately, Latinos aren't benefiting in the same way. And so at Amgen, we are making a big commitment, and there's a big internal focus in making sure that we're expanding access to and participation of racial and ethnic minorities in our clinical trials. And one of the ways we're doing that, as Dr. Murillo mentioned, is we've partnered with the Lazarus Cancer Foundation. Back in 2017, we gave them a $2 million donation, and they partnered with USC North Cancer Center and UCSF. And in 2 years, they were able to increase minority participation in their trials by 63%, 52% of which were from households of under $25,000 that made under $25,000. So when you have these trusted messengers, and you have a concerted effort, and addressing the barriers, right, the ancillary costs of the transportation, the lodging that oftentimes aren't covered. When you have trusted messengers educating around what are clinical trials, what are the implications of participating in one, that is how we could all make a difference. And it's definitely a multi-stakeholder, all-hands approach in reaching these communities. So I just wanted to add, industry absolutely has a big role to play here in making sure that we're starting on as early as possible with our research.
Perfect.
I would also add the importance and link to the topic that we are discussing, that is clinical trials, the importance of virtual technology, just to really drive the trials and increase more representation from minorities. And I just want you to know that and I agree that the industry has to evolve on that, and we have a big role to play there. And earlier this year, we published some diversity data from our clinical trials going back 10 years, which for us will offer a very good baseline for improvement, and will also serve as a catalyst for us to build a library to guide future decisions, just to ensure that we have representation of all populations. And as I said, I agree that as an industry, we have to take more actions to drive this. And as I was saying, technology can be a very important tool, because virtual clinical trials can help to increase the participation and can allow participation without barriers such as geography or mobility concerns or schedule. So we are, in our company, we are fully committed to work towards the goal of designing clinical trials in a way that the enrollment will really represent all populations and in those trials.
Excellent. And now let's talk a little more about access. What are some of the access-related barriers to healthcare facing Latino community, and how are you thinking about addressing these barriers?
Well, again, if I can just throw something out. In terms of access for Latinos, here's where research comes in. The need for principal investigators who ask the right questions. I teach a graduate seminar on theory, method, and data in Latino health research. And not only are we studying this Latino epidemiological paradox, we're studying the fundamental question. They're really fun. What is, from a scientific biomedical standpoint, really, what is exactly Latino? And who then gets categorized as Latino so that they get into our data sets? And that's a very mushy concept. That whole idea of what is Latino really needs some scientific rigor, because we get some very squishy things happening out in the real world in terms of people being identified as Latino or not on a birth record, on a death record, in a clinical trial. So we're not even clear as a science what exactly is Latino and why are we measuring it, but we can see there are clear outcomes in denial of access or in organic reduction of risk to heart disease and cancer by 30%. This is a fertile field, but we don't have very many people looking at it. And when they go out, they often use antiquated tools. We need new tools for 21st century biomedicine.
Yeah, if I may tag on that comment of the new tools, you're absolutely right. In terms of solving access, there are many fronts that we can work on. For instance, we alluded to the concept of delivering a more diverse workforce. And Dr. Hayes Bautista is working on that. Since 2007, the the United Health Group Foundation has also given more than 100 million in grants for people to train in the healthcare areas, not necessarily just UHC or United employees, but really any community-based candidate. So we promote the formation of this workforce in a diverse workforce. The other area where I think it's important is that I mentioned the partnership with local communities. That's another way to gain access. The other area is telemetry, and I think with telehealth in general, you saw how during the COVID times, it really took a prime spot, and that's an area where I think we have an opportunity, and it's not going to be just us in the private sector. The government is making efforts to provide broadband access to rural communities, for instance. So we're promoting the concept of telemetry, of telehealth is important. It's an opportunity for them to access care from their houses, even starting from, hey, what do I do? To here's where we can get the best care for what you have right now. Obviously, we're not talking about emerging conditions, we're talking about chronic conditions, and also an opportunity to use technology for us to monitor how they're doing. We need to move from that space of fee for service where we just pay for a visit to, is your blood pressure controlled? Are your outcomes better? Are you having less of, are we detected cancer earlier because we were visiting? Remember, the Latino community spends less in healthcare than other races and ethnicities. And why is that? It's not because it's cheaper for them. It's because they don't seek care, because they are working and they cannot afford the time to go out and spend half a day or a full day waiting for a doctor. So we need to create the conditions for them. We need to create the access convenience that they need. We need to create more affordable care, and that care has to be more individualized. And that's what we're committed. United and many others are committed to do it, not just as ourselves, but also in partnership with other organizations.
Perfect.
Yeah,
We're going to go to our questions. Hold on, Beatriz, sorry to interrupt you. We're going to go to our questions in a little bit, and I just want to ask one question. Probably, Beatriz, you want to jump in on this one. We often talk about the social determinants on health and the social communal factors like neighborhood, environment, and education that predict health outcomes. But what about the political determinants on health? What are the political factors that impact Latino chronic illness? And what are some of the ways to address those factors?
Okay, I can jump in there. So I think that in order to develop successful solutions, and it was mentioned before by some of the panelists, it's very, very important that we all work together as a community. So in Pfizer, what we are doing is we are breaking down barriers to care by engaging elected officials at federal, state, local levels on key policy issues, healthcare access in multicultural communities. And of course, we are also working with organizations like the Congressional Hispanic Caucus Institute just to bring a greater focus on those important issues to our governing bodies and ensure that legislators are aware of the community's unique needs. So again, it's like working together to address these issues will help us to find solutions.
Perfect. Anyone else wants to add?
Sorry, but I just want to add, I think you touched on a really important issue, the community part of the story. And I'm going to illustrate that with a point. In Colombia, and I know there are many other countries, there is a role, it's called promotora de salud. And the role of these people are people who are actually trained for a few months. They are part of the community. They go out to rural communities. They check with everybody's blood pressure, blood sugars, vaccinations, and so on. And then based on that, they inform the local provider and say, doctor, we need to have a vaccination campaign here. We need to have blood pressure campaign here, and so on. I think that's an opportunity for us to, in the United States, to move into the community, extend the ability of the healthcare teams to provide primary care, to provide chronic condition care. So that's something that we definitely need to expand on and explore further.
Perfect.
And,
Excellent.
mhm.
Hold on, Dr. Bautista. And actually, probably you can answer that and also answer one of the questions. We're starting to have so many questions from the audience. And if you want to add a little bit about that, but also answer what would you say root causes of the deficits in the Latino healthcare workforce?
Well, you talk about politicization of healthcare and medicine. Absolutely. The reason why we have so few Latinos, this is the heritage we have of race science in the 19th and early 20th century, of segregation laws, the Jim Crow laws, the laws that put Latinos into quote unquote the Mexican schools. This is a result of all of that. And what we need to combat it is better leadership, particularly from Latino providers. In fact, we're starting a program to develop Latino physician leadership so they can take their case either to their colleagues in the C-suite or to the public about Latino health and how that undergirds the economic growth of the U.S. economy. We are the only growth point. We need to take care of its health. A healthy workforce is a productive workforce, and we need Latino physician leadership to make that case.
Perfect.
I
And I
think also
interrupted you, Doctor. I'm sorry. I interrupted you, Dr. Bautista. You wanted to mention something about the previous question about the political part?
Well, healthcare is structured in the U.S. the way it is because of political decisions made at the federal and state level. We are the only advanced industrial country during the COVID pandemic where patients had to make the decision, do I go in to get tested and pay the price of $200, or do I pay my rent? When I talk to my colleagues in Spain, physicians, they shake their heads. In Europe, a patient doesn't have to make those kinds of decisions, care or food, care or rent. Because the care is there, they know it, they can go ahead with their lives. But because of political decisions over the past 150 years, we spend twice as much as any other country. We're the least healthy of any of the major industrial countries. Political decisions. It's not that we need to get politics out of medicine. It's always been there. We just need to make sure the participation is more equitable.
Thank you. Thank you, Beatriz. Now you can go ahead. I'm sorry that I interrupted you. You were going to talk about the root causes of the deficits in the Latino healthcare workforce.
Yeah. Now I wanted to build on what Dr. Hayes was saying, and I think it's important for increasing the number of healthcare professionals from the Latino communities. I think it's also important that the medical societies work together on this, and I want to share as an example that the American Academy of Dermatology, for example, has released a 3-year diversity initiative that is focused on improving inclusion and leadership, and then increasing the number of Latino doctors in the leadership team. So it's important, again, going back to what we were saying, that we all work together on this.
Thank you. And now we have a question for Michelle. What is the relationship between these kind of inequities around chronic illnesses and mental health? How can we ensure mental health remains part of the conversation?
Yeah, I was so moved by Representative Napolitano's comments because there's still a lot of stigma in the Latino community about asking for help. And over the last 18 months, I think it's particularly in this country, it's finally at the forefront. It's being acknowledged as a topic. We've seen it in different areas of cancer. Lung cancer, it's still very prevalent, but now as a society, taking a step back and just, focusing on the mental health and not being afraid to ask questions. I think it has to start there. As I think about, and I didn't chime in earlier, but one of the biggest access barriers remains the language and the health literacy. Are we, all of us, as different stakeholders, putting information that, somebody who's not in the medical field can understand? And we still see that there's a gap when it comes to understanding side effects, when it comes to understanding pain management, as well as psychosocial issues. And so, to me, this is all very interrelated, but, addressing the fact that you're not weak, you can and should ask for help. That should be, top priority for all of us.
Definitely. Thank you so much. We have another question from the audience. Is what can we do to address the mental health of both patients and healthcare providers when facing chronic conditions?
I'll jump in, and I think the mental, if you think about post-COVID, hopefully the pandemia will resolve, and yes, COVID is not going to go away, but post-pandemia, mental health is arguably probably the biggest area where we need to tackle. So that combination of chronic conditions and mental health is going to be key, because if we address the behavioral aspect of the story, if we address the social aspect of it, then we're going to have a whole of people who had both. So the aspect of mental health facilitated, again, by what Michelle was saying, health literacy, communication, ideally utilizing language, but in a culturally sensitive way, is an ideal way to engage people. So in that engagement, the engagement of people in their own care, is probably a paradigm shift that we need to make in healthcare. As everybody knows, healthcare has always been seen in a very one way: is that I'm in the office waiting for the patient to come in with a complaint, or in the ED waiting for them to come with an acute event. And we need to change that environment. We need to make it more bi-directional. We need to allow people build an ecosystem where they can communicate with us. And the mental health space is a critical one, because they need to have access to, and you saw Representative Napolitano talking about having a 988 line available soon for people who need help. And we all need to be organizationally be prepared to address the tsunami of mental health issues that we need to tackle, along with the chronic illness concept.
Excellent.
I think also,
Go ahead.
Go ahead, Beatriz.
Anyone, Beatriz or Dr. Hayes?
go ahead.
Beatriz, please.
After you. Okay.
Okay, well, I just... Go ahead.
I was going to mention the use of virtual technology too, as I mentioned before, because not all patients will feel comfortable talking about their mental health issues with their healthcare providers and going to the clinics or the hospitals to see these providers. So also think about how we can maximize the virtual technology to have these good conversations between healthcare professionals and the Latino community would be something that would need to be explored more.
And if I could just add in, particularly in mental health, where communication is really, really important. I've heard, for example, people say that, well, Spanish is a barrier. It is not a barrier. Take the case of California. Health services have been provided in California in Spanish every single day for 250 years. It's nothing new. In fact, California came in as a bilingual state, as did Colorado, as did New Mexico, many others. Spanish is a language of the United States, but politically, those provisions were ripped apart in the late 19th, early 20th century as the medical community turned its back on the needs of the Spanish-speaking population. But speaking Spanish is part of American history. In fact, Western folks spoke Spanish before English in the United States. It is American to speak Spanish, and we need our physician and dentist and nurse workforce to represent the history of the United States.
Perfect. Thank you. We're going to go with another question since we're running out of time. Are there studies that have looked into the effectiveness of promotoras de salud?
That's a great question. Yes, not in obviously in the United States space, but in Colombia, where medicine had a major reform back in 1995, and since then, you have, in terms of access to care, it's almost universal. In fact, it's even enforced by law. If you have an issue, it has not been taken care of, that patient has the ability to actually, they do it, unfortunately, but they have the tool, the mechanism to actually go to a judge and say, and the judge will say, you have 24 hours to respond to this medical issue. So, but not to say that that's the primary mechanism. The idea is expanding access to care through this Promotora de Salud has at least provided primary care access in the rural areas, which most people don't want to work. We know that. So that's a really good mechanism of doing it. And also, you know, you don't have to go to rural areas in the United States. There are many areas where poor neighborhoods where nobody wants to provide care either. So that's an opportunity. And then the concept of trust. I think that's probably one of the biggest advantages. If you have a promotora de salud embedded in that community, that's where you can really create trust and effectiveness in care. So it is the benefits demonstrated, and that's why we've been doing it for many decades, and we should adopt that.
Perfect. I'm gonna go to my last question. How can we provide equitable healthcare for undocumented immigrants who live with chronic conditions?
Well, again, let me look at the other countries we compete with: the United Kingdom, Italy, Spain, Germany, etc. In those countries, you have, if you are in the borders of the country of France, you have access to care, period, irrespective of what your immigration or racial situation is. But here we have, again, because of political reasons, decided to exclude a certain category of people. In fact, if you consider that about 3/4 of all farm workers are undocumented immigrants, the very undocumented immigrants who fed us during the past 18 months of the pandemic so that we had adequate food supply in our stores, and then we exclude them from care. Again, most other industrialized countries scratch their heads and say, what are you guys doing? But that's what we have done.
Anyone else?
Yeah, when it comes to healthcare, we strongly believe that the concept is building a healthier community, and that's why we had this debate in a previous panel where people say, why are people being asked for ID when they come to access? And maybe to Dr. Hayes Bautista is a political issue, but we believe that providing care, it has to be provided regardless of your race, gender, sexual orientation, color, and even legal status. So that's why we go out and build healthier communities. One of our priorities. And building healthier community doesn't mean healthier communities for some and not for others. So equity has to be part of that, and I think that concept has to be embedded into healthcare regardless. And we remember in the clinical world we have an oath, which is we serve everybody regardless of their status, and we need to be faithful to that mission.
Perfect. Thank you. Thank you so much. And we're going to go to our last question. And if each one of you can tell us what is one thing our community's healthcare industry or policymakers can do to advance equity in Latino chronic conditions. And what is your hope for the future? If we can start with Michelle.
Oh, you went backwards this time. Okay. So for me, it is engaging the community early on, whether it's in clinical research. I think it's fantastic to have the diverse set of panelists you have today because, Dr. David Hayes Bautista is playing such a role with the physician community, but then Dr. Murillo is with UHG, right? So we do need to have all the stakeholders at the table and understanding what barriers. My hope for the future, honestly, is, that we give the Latino students of today exposure to STEM education, to policy making, to broader healthcare communities, because they're really going to be the pipeline, to the future in addressing these issues. And so getting them a seat at the table and a voice will hopefully mitigate some of these.
Perfect. Beatriz?
For me, it's very important, as we've mentioned, that we increase the number of healthcare practitioners that are from the Latino communities and other minorities. It's important that we increase the representation in clinical trials, as we've mentioned, and that we develop every material, and Dr. Hayes was talking about it, in Spanish, so they can really understand everything. And then my hope for the future is that we all work together independently of being like in the academia or in the industry or the governmental level, that we all work together just to really develop a society that has equity when thinking about health.
Perfect. Jaime?
Great, thank you. Well, first of all, I want to thank the Congressional Hispanic Caucus Institute for this invitation. I think, as you have all seen, has been a tremendous conversation, and we hope that a lot of comments will really be converted into realities in the near future. So a couple of things. One, and I think is a common theme now so far, is can we expand care through the community. And I think we all believe in it. We talk about the concept promotora de salud. Is there an opportunity, is there political will? Is there an organizational leadership will to build those? I think we can think of setting an economic platform where that type of jobs like promotora de salud or health promoter embedded in the community can have a sustainable way working along with local healthcare systems or local providers. So that expansion, I think, will definitely have a lot to provide. And then the second one is this concept of partnership. And we have taken a very thoughtful approach to providing care through partnership with local communities. That's an important aspect, and there's a call to action and up to all the organizations partner with local communities because they have that trust, they have the relationship, they know everybody, and I think we can serve as a resource, and we can together build that a better health within that community because at the end our mission is united is make the health system work better for everyone, but more importantly, make people live healthier lives. And interestingly, I'm going to finish by saying that equity is a measure of our mission success, and diversity and inclusion are the formula to get there.
Perfect. And Mr. Bautista.
Yes, equity will be the result of good leadership. Actually, we are working UCLA with the Los Angeles County Medical Association. We're creating a seminar to develop Latino provider leadership, starting with physicians, nurses, dentists, etc., so that they can gain their voice based on their lived experience. Take that into the practice room, take it into the research room, take it into the lecture hall to let the medical world know what Latino health is all about, so that the decisions that get made in the future have that voice. Diversity without voice doesn't change anything. Diversity with voice will help us gain the future. So I invite you all to partner with us on this. We want to take this program out of LA County to the entire country. We think we can actually achieve that vision.
Perfect. Thank you. Thank you so much to our wonderful panelists for your time and for your important work. And thank you for attending CHCI Leadership Conference. Please keep tweeting about the summit and sharing your thoughts at hashtag CHCIHHM21. We have a very interesting plenary session coming up on the topic of infrastructure and transportation, and make sure to check it out. Thank you and have a great day.